Okay, order. Welcome back. This is the second panel of our second public evidence session on our inquiry into pharmacy, both community and hospital. We are now in panel 2 looking at workforce, and we're going to be talking about all of the issues around what a pharmacist or pharmacy technician of the future might look like, and the challenges that that brings to the sector and the opportunities that that brings to the sector. Let's introduce who we have before us. We have Mark Zoyle, who's chairman of the Pharmacy Defence Association. Nice to see you. Duncan Rudkin, who's chief executive of the General Pharmaceutical Council, referred to in the last session, so your fame goes before you. And Nicola Stockman, who's vice president of the Association of Pharmacy Technicians. Thank you so much for coming in, and we're probably going to run this for about 45-50 minutes, certainly no more than the hour, and I'm going to kick off. I'm just going to start with, probably with yourself, Duncan. What are the live ones at the moment when we talk about pharmacy workforce of the future? And there's obviously a lot of debate around pharmacy technicians and how they sit alongside pharmacists. You heard we were talking a bit about independent pharmacy prescribers being able to deal with medicine shortages, which is one of the biggest challenges facing the industry at the moment. What's the biggest issue facing pharmacy workforce at the moment?
Well, it might strike some of my colleagues as odd if I start with well-being, because actually we haven't mentioned that really this morning so far. And from where we sit, we're very aware of issues affecting the well-being of the profession, and we're very mindful of the fact that then has a patient safety implication. So obviously, as a regulator, our primary focus is on the safety of the public and the safety and well-being of patients. But we see that as inextricably bound up with the well-being of the profession. And we know that in many ways, members of the profession are having an exceptionally difficult time at the moment. So I would want that to be sort of high up there on the agenda.
Yep.
I'm sure we'll want to come back to that. I guess, secondly, perhaps more obviously from a regulatory point of view, everything to do with a skill, competence and capability of both pharmacists and pharmacy technicians, but also I would say the wider pharmacy team, including members of the team who are not registered. So for us as the regulator, ensuring that the people that we regulate in every sense have the skills and competence and confidence that they need now and in the future is obviously a key strategic objective for us. So there's a lot of work going on around that. And then I guess there's a really important set of issues which are to quite an extent legal, but also regulatory and professional issues around skill mix, by which I guess I mean making sure that all of the elements are in place to enable all members of that team to maximise their contribution to care, so that pharmacists are doing what only pharmacists can do, pharmacy technicians are able to do to optimise their contribution, and other members of the team can do the same. And some of that is about confidence and competence, but also some of it is about making sure that the legal and regulatory framework enables all of that. So perhaps I'd leave it there with those three main headings.
That's the perfect framework. Can I ask you then, as the regulator, the long-term plan, the NHS long-term workforce plan, says that education training places for pharmacy needs to grow by between 31 and 55% by 2032-33 to meet the demand for pharmacy services. So it also talks about expanding training places for pharmacists by nearly 50% by 31-32. In your opinion, is that plan deliverable?
So that is obviously a very ambitious set of objectives.
Yeah.
We also got in mind a shorter time horizon around the deadline of 2026, when all newly registered pharmacists will be prescribers or be annotated as prescribers at the beginning of their registration, whereas currently, of course, as you know, becoming a prescriber is an additional qualification, effectively an annotation. And we know that there are because we have a group, we've brought together a group of all the key actors who are looking to try to effect that 2026 change. We know that a key issue, a key concern and a key risk in that change that our colleagues are concerned about and continually working on is around making sure that there are adequate placements with the right kind of clinical exposure, but very importantly, an adequate supply now and then pipeline of existing prescribers who will be able to support training of prescribing pharmacists. So we know that there are challenges now, which we and others are working on, around getting to that 2026 change. And then looking beyond that, obviously there are a number of different elements to the objective you outlined, Chair, including making sure there's an adequate supply of M-Pharm places for training of pharmacists, making sure then that there are adequate numbers and quality and breadth of training placements and the trainers to support those trainings.
I just finally for you, help me understand this, because William Pett from Healthwatch was saying that the community pharmacy sector has had a brutal haircut and has smaller numbers than they've had ever, and yet we're talking about growing the workforce by up to 55% to meet demand for pharmacy services. So my simple brain says that there's going to be a gap between the numbers that we're talking about bringing in, if that is delivered, and the places where they might deliver those services. Or am I missing something here?
Well, we've got to look at the numbers of pharmacists as well as the numbers of pharmacies. The numbers of pharmacies have gone down in the last few years. We've also seen an increase in the number of pharmacists on the register. Mm-hmm. There's a debate raging, one might say, about whether the system as a whole, has got the right numbers of different types of workers in the right places. But we haven't touched so much on hospital as well. So there's obviously a significant number of training places in hospitals, which would be part of that overall training capacity.
Well, let's do that then. That's a perfect bridge to your left, to Nicola, because obviously you have a role at Hampshire Hospitals, which is becoming a Hampshire Day. Obviously, Hampshire Hospitals Trust partly covers my constituency at Central Mid Hampshire Acute Trust. What do you think about this long-term plan ambition and its deliverability with respect to hospital pharmacy?
That's a really interesting point. Thank you for that. What I would like to caveat that with is that I'm here in my capacity as APT UK Vice President, but you're absolutely right. I have a day job, and it is at Hampshire Hospitals.
I want to just say for those watching the acronym that you just gave.
Yes, the Association of Pharmacy Technicians UK and Hampshire Hospitals Foundation Trust. Yeah. So I think that we do have in the workforce plan a pledge to grow pharmacy technicians. There's not as many numbers on that as there are for pharmacists. And it is about having the right people in the right place with the right skills for the patients that need it. I think that from a hospital point of view, there are more pharmacists per place than there are in the pharmacy in the community, and their knowledge and skills are far utilised. There's also not many of them either, and they're looking to deliver more. The wards, there's more wards, there's more patients coming in. It's tough in pharmacy at the moment. It is tough, and I think that to make sure that we've got the right people in the right place, we need to look at the skill sets of everybody. So that's pharmacists, pharmacy technicians, and make sure that the model we've got is fit for the future. So in hospital and community, I would say that applies across the board. Pharmacy is a very valued service, but there's never enough of us.
There's never enough. Okay, right. I'm not going to just go to everybody on this because other colleagues want to put questions to Mark. So I'm going to start now going out to Paul Blomfield first. And Paul, you can pick up the threads.
Well, let me take that cue and put a question to Mark. Duncan focused on the issue of well-being, in the profession, and we've had some pretty sort of damning evidence in terms of the pressures on pharmacists, and certainly when I talk to community pharmacists in my patch, these are committed people who are struggling. How would you describe morale in the workforce?
So, first of all, thank you very much for allowing this committee to hear from the voice of the workforce. It's not something that happens very often. Pharmacists tend not to get too much of a voice in this situation. So we represent employee and locum pharmacists. We're a defence association, so we help them when things go wrong. So we understand an awful lot about the causes of issues. And much of what I'm going to say to you is fuelled by that morale at this moment in time. So we don't have any owners in our organisation, just employees. What happened with the funding cuts, which has got nothing to do with our members, ended up with massive staffing cuts. It was the only mechanism that the employers had available to them to try and make ends meet. You've seen huge cuts right across the sector. In community pharmacy, I'm talking in England, particularly in all parts of England, 20% is the cut in pharmacy technicians that are available in community pharmacy reductions now in England compared to what it was just 5 years ago. You've got cuts in all of the other grades of staff. Meanwhile, the volumes have gone up and up and up. So it means that the pharmacists, who are all healthcare professionals who want to help patients, the only thing they want to do is to make patients better. They are forced into a situation where they can't follow all the protocols as they should. They have to start making decisions as to how to make ends meet, how to deliver services for patients in a deteriorating environment. That is not an ideal condition in which to practice for 6 months, for a year, let alone for 3 years and 5 years. That's what's been happening. So that's had a huge effect. Business behaviours. In community pharmacy in England, you've got some very, very large multiple operators. Now, they are owned, much of them, by large corporate businesses who want to buy and sell those businesses. While they are buying and selling those businesses, they have to do things like cut your holiday entitlement, cut your pension arrangements, other arrangements, non-pharmacist area managers who are giving people targets to do, commercial targets, as opposed to clinical arrangements around patients. Those arguments cause all sorts of problems. You've then got the problems around the shortages of medicines, where members of the public, quite understandably, are coming in, and the only people that they can vent their fury on are the pharmacists and the pharmacy staff that they're facing, in a way that in secondary care or even in GP practice, it's often the receptionists or people at the front of the hospital that get that. In the community pharmacy, they get it as they walk in off the street. On top of that, ended up being the COVID crisis, which, as you know, community pharmacy was the only place that was actually accessible and open to members of the public, with all of the incumbent problems and frustrations and grief that brought with those. You end up with community pharmacists facing lots of violence and abuse. So all I can say to you is we give £1 of every single one of our membership fees to Pharmacist Support, which is a charity that looks after pharmacists who are on the edge of mental health issues, well-being issues, concerns around that. They have been at record-breaking levels these last few years. So morale in community pharmacy currently, and the staffing shortages that continue to be in position, have massively affected the morale of the community pharmacist workforce.
That's a depressing start for our discussion, but you paint, I'll come to you in a moment if I might, Duncan. You paint a sort of multifaceted problem. I mean, we're looking to, as a committee, to make recommendations to government. I mean, where would your recommendations be in seeking to begin to address those issues? What are the priorities?
So there are lots of exciting developments on the horizon. It's already been mentioned. Independent prescribing qualification is a major one. I think that the answer to your question is, and it doesn't just apply to pharmacy, it applies to the whole of healthcare, but particularly primary care, is why don't we start working smart and not just working hard? We have a situation today where we've got about 7% of hospital beds filled by patients that have been harmed by adverse drug reactions. 20% of over 65s are admitted to hospital because of the effect of adverse drug reactions. Medicines are the second largest item on the NHS budget, and yet what care and attention has been paid to medicines specifically, and pharmacists are the healthcare professionals that are trained in medicines. So the answer, I think, to your question is, get pharmacists to be pharmacists in the healthcare system, get them to focus on medicines issues, because that will be to the benefit of the public, to the benefit of the NHS. If a large proportion of people are trying to contact their GP every day and they can't get through, but they've already been diagnosed by the doctor, so now it's a question of getting their maintenance doses of whatever it is, cardiovascular or diabetes. Those medicines management issues could be taken care of by pharmacists. Those patients need not go back to the GP surgery, and that will have the inherent effect of reducing the queues that the GP practices are facing. So we would say that the exciting possibility for independent prescribing is to enable patients to get a medicines champion. The pharmacist should be the patient's medicines champion. As Deborah pointed out in the earlier presentation, it takes about half an hour to do a really detailed assessment and to get those patients to build up the trust in the pharmacists and see them as an agent for beneficial change. Now, this is all about more than one pharmacist in the pharmacy. There's no question about that. The existing workforce infrastructure is so fragile, you couldn't add any more services in on top of it because it's already at breaking point. So you need to start moving the community pharmacy so it becomes more of a clinical operation with more than one pharmacist working there, and at least more than the complement of pharmacy technicians that we've got at the moment, which is 1 per 2 pharmacies.
You make a really striking point there. It's a substantial culture change. Do you think that the pharmacy sector is comprehensively and consistently ready for that across the country?
So it depends who you call the pharmacy sector. Are you talking about the owners and the employers, and particularly the large corporates, or are you talking about the actual workforce? I can talk for the workforce. They want to care for patients. They want to use the skills that they've been taught at university to the best effect. When we do the focus groups with our members and the surveys, one of the biggest frustrations of the young ones, which was a phrase that was termed earlier, is that actually this practice doesn't resemble what I was taught. Why aren't I using my skills, particularly in the community pharmacy setting? So the workforce is ready for that, subject to us being able to alleviate some of these crazy staffing shortage situations. If we could create a safe environment where they could spend enough time with patients, they would embrace that clinical role. But your question about are the business operators ready for that kind of change, well, that's another question altogether.
Okay, I'm sure we'll come back to those issues. But Nicola, what's morale like for pharmacy technicians?
I think it's very much the same. The thing is that for pharmacy technicians, as soon as they're training, because it's an apprenticeship route, they are in that workplace. They are in the environment that we are describing that is under a lot of pressure. So day one, that is their learning environment. In the same way that post their university experience pharmacists in their training year, that is their learning environment. It is tough, and I think that we need to support each other within the pharmacy professions to make sure that we're investing in the future workforce as well as retaining the ones that are there. So when the workforce plan talks about training, retaining, and then, what that looks like in the future as well, actually training and retaining are linked, because if you don't have those that are retained within that environment, they're the ones that are teaching and overseeing those that are supporting and starting on their career. So those early years are really important, and you're completely right, and actually you are at the front line. The frustrations from medicine shortages, or people that are actually quite potentially frightened. We heard in the earlier session about someone that really needed something checked out, and they come to you when the patients come to the pharmacy because they need that reassurance, they need that support from the pharmacy professionals who are trained to deal with it. Without that, we need them for the future, is basically what I'm saying. So if we don't get those early years right, we are also going to see that retention drop off. So I can't stress enough how important those early years are. So training and retaining are so inextricably linked that morale is tied to the environment that they're operating in. So that's reflective of the answers you've heard from everyone.
Thanks very much. I'm sure we'll come back to some of those issues. Duncan, I know you're itching to get in early, but I wanted to ask you something specific, and it's an opportunity to make another point. I mean, in your submission, you talked about prejudice, discrimination and racism as a problem. How widespread And could you kind of elaborate on that and what needs to be done?
So I think we've had lots of really interesting and important discussions with a range of different colleagues from different parts of pharmacy over the last year or so, particularly around this topic. And as a result of that, we're raising the profile of that issue within our own work, and thereby also hoping to encourage others to do the same, to be part of that wider conversation. Firstly, because we have some important statutory obligations, but more fundamentally for reasons of humanity and doing the right thing. There's also a really important link, I think, through with actually capacity, capability and confidence, because we've heard some really upsetting, distressing examples of stories from colleagues in pharmacy in different settings whose confidence and ability to optimise their contribution to patient care has been dented by their experience, for example, of racism in the workplace. So it's really important that is tackled for all sorts of reasons, and there's a link through, I think, with patient care. So yeah, that's clearly and rightly, I think, a high-profile issue. The Chief Pharmaceutical Officer for England leads the Inclusive Pharmacy Practice Board, which is also helping, I think, to raise the profile of that issue and to challenge all of us to do more, to do better, to tackle discrimination, racism, bullying, harassment within the pharmacy workplace, because it can be so corrosive in all of those different ways. The point that I wanted to make, just really to add briefly to what Mark said in answer to your question about morale, and I think we heard some of this as well in what Mark said later on. In the various engagement events we've held in the last year or so with pharmacy team members in kind of listening events, but also in all the informal conversations we've had in a range of different settings, there is all of those things that have been described. There is also a considerable degree of enthusiasm and excitement for change. I don't myself see resistance to that as a key issue within the profession, but there is a realistic and quite proper concern by pharmacy professionals about those questions of, are we going to be able to maximise what we can do? Are we going to be able to take advantage of these opportunities, which we want to do, is what I'm hearing, because, for example, we're spending so much time dealing with shortages, we've got all of these pressures that you've been describing. So the will, I believe, the will is there, but there's quite a proper set of questions being asked of all the various authorities involved to say, you all need to make sure that we're enabled and supported to do this, but we really want to.
Thank you.
Very good. Thanks very much. Right, James Morris.
Thank you, Chair. Yeah, Mr. Rudkin, obviously there's a huge amount of change happening in the sector, new demands and so on. Do you think that changes what you need to do as a regulator?
Yes, it certainly changes what we do and how we need to go about it. So we've been looking at that ourselves in terms of our own organisation, our own competence and capability, and what kind of skills do we need to have within the regulator. It's not that long ago that for example, where we were dealing with concerns and complaints, that they would pretty much all be about things like dispensing errors, supply issues, and so on. We are understandably seeing a growing kind of caseload around clinical issues, which has encouraged us to build a new team.
When you say clinical issues, do you mean sort of malpractice that then gets escalated to you? What do you mean by
I mean,
that?
for example, issues around prescribing judgments,
Right, okay.
that kind of thing, which wouldn't have been put in our caseload previously. So we've been building, for example, in response to that and looking to the future, a different kind of workforce really within the GPHC. We've always had inspectors who've been pharmacists, mainly pharmacists, some pharmacy technicians. A growing proportion of those have been recruited specifically as clinically focused inspectors, many of them currently prescribers themselves and still actively prescribing, and building our capacity and capability to understand those issues. We've recently hired a senior pharmacist as our first chief pharmacist within the regulator, right, to strengthen our ability to engage with the profession across a range of those issues.
Thank you. Nicola, in representing the pharmacy technician role is relatively new, and I just wondered how you felt it was working in terms of fitting into the pharmacy environment.
That's a great question. So you're absolutely right. The profession has been regulated since 2011. So compared to pharmacists, yes, we're fairly new. We definitely have a place there, and we have supported capacity within the pharmacy teams. We have a home within the pharmacy. But what we're seeing is that we could do more. So actually the potential following the initial education and training from 2017 that's now embedded within pharmacy technician training means that we now come out as accuracy checking pharmacy technicians, which means that we can be checking those prescriptions for accuracy before they go out to the patients. But we can do more, and we're talking about capacity, and we can see that there is potential for our profession regarding the consultations that are out. One is out now around supervision, and one is just closed around patient group directions. Mm-hmm. There is a place for pharmacy technicians within that. We have the skills, knowledge and behaviours to be able to support that, and we are putting patients first. We're also held to the same professional standards as pharmacists by our regulator. Mm-hmm. So we are well placed to support the capacity, and the potential is only greater.
Do you think the public understand what a pharmacy technician is?
Probably not enough,
right,
actually. Yeah. And the reason I say that is because even in the first session, for example, it took a while for pharmacy technician as the profession to come into the discussion. So I think there is definitely some work we need to do around that, and that is around positive reinforcement from other professions. So in the same way that confidence in pharmacist independent prescribers will need to be reinforced by other professions, the same within the pharmacy professions for us. So pharmacists will need to reinforce that confidence for pharmacy technicians. We need to do it ourselves. But it's about looking at the patient journey and how we all link in for that patient and breaking down some of those more traditional barriers. So we all need to be supporting each other in this, and that goes wider than pharmacy.
You painted a picture of a kind of profession where morale was pretty rock bottom or pretty low. So what needs to happen in order to raise that morale? What recommendation would you make to us?
So the big question that came up at your last session in November and also this morning is this whole thing about sourcing and buying and purchasing medicines, which right, I know committee members were interested in. When I first qualified as a pharmacist, you spent a lot of time mixing creams and ointments. That's all been taken away, and it's all done in factories. If we could move away from the pharmacists being involved in the purchasing, the sourcing, the buying, some of our members are spending 4.5 hours a day trying to find one medicine, and they're not facing patients in a clinical situation. Mm-hmm. If we could move to a situation where actually all of the prescriptions are now generated electronically, if when the pharmacist arrives in the morning, those medicines are already pre-bagged, pre-checked and pre-labeled in the pharmacy, and there's technology out there that can enable that to happen, pharmacists will spend all of their time on clinical issues as opposed to assembly and preparation. During the supervision sector group report that's just convened over the last 6 months, that was one of our recommendations to the Department of Health. Change the legislation to allow assembly to be made in some other way, so that once the pharmacist arrives in the morning, their role is the clinical check, because that's where the value is. That would take a huge amount of unnecessary workload away from the pharmacist. And then it's a question of dealing with the clinical issues on patients. Two elements to this: the appointment-led caseload work, where we're taking pre-diagnosed patients from doctors and helping them maintain their diabetes medicines, their asthma preparations. And then the second one is the population health model, where our pharmacist is standing there patient-facing. In comes a patient that wants to buy an anti-diarrhea preparation, but the pharmacist knows that that patient is taking an ACE inhibitor, and immediately has to advise that patient to stop taking the ACE inhibitor for the next 2 days, otherwise they're going to end up with acute kidney injury. 150,000 people a year in the UK die of acute kidney injury. Now, that's the kind of clinical application in a population health model that community pharmacists could be
That's a fundamental shift, isn't it, in the kind of business model of the pharmacy?
Absolutely. It is a very
Would you agree with that as the future direction, Mr. Rutkin? Do you think that's...
in as much as that absolutely is about maximising the contribution that each member of the team can deliver and using technology in the right way, then absolutely.
Okay. And technology, Nicola, do you think it's got the potential to achieve the transformation that we've been talking about?
Absolutely, because the capacity, if there's certain elements of the pharmacy service that can be automated safely, then that frees up the pharmacy professionals to best utilise their skills in patient-facing, which would then reassure the patients in confidence in pharmacy, which can only be a good thing.
Thank you, Joe.
Thanks. And just on the medicine shortages, Duncan, you said in your written evidence to us that there was unprofessional behaviour associated with medicine shortages. What did you mean by that?
Well, I think we've recently, with a few months ago, with the other leading a discussion with the other professional regulators, issued a joint statement to all of the registered healthcare professionals in the country, reminding them of, for example, the National Patient Safety Alert in relation to GLP-1 agonists. I'm not a pharmacist, so forgive me if I got don't get the exact detail right, but this is where medicines that are in serious shortage are needed for use by diabetic patients maybe in some cases be being prescribed off-label for other purposes, including particularly weight loss. So there's something around making sure that prescribing judgments are mindful of shortage issues. If I may, Chair, while on shortages, there are a couple of other things that I wanted just to mention. One is that there were introduced some years ago things called serious shortage protocols. I don't know if you've looked at those, but I'm sure you're aware of them. And it may be time to look at whether there's more that can be done with those. And the other thing which I think I just wanted to mention, which picks up on something that Deborah talked about earlier when she was talking about, as a prescriber, her ability to prescribe an alternative in the case of a shortage medicine. I think it's really important in all of this that and there's a lot of focus on prescribers. There's 40-odd thousand pharmacists on the register who are not yet prescribers, but have a lot of those core kind of underlying skills and competence based on, in many cases, years of over-the-counter prescribing. And is there more we can do with them in terms of, for example, looking at the legal framework around when is a pharmacist able to vary what they supply against a prescription in order to make the most of that knowledge and skill. But that's perhaps just an example of a wider issue about those non-prescribers, and it's important we don't miss out on that large number and focus all of our energy on the new ones, as it were.
Okay, no, that's what you meant. Fine. Right, Rachel Maskell.
Thank you ever so much. Fascinating discussion. Duncan, if I can start with you, and I want to ask about regulation. And we're seeing greater skill mix now being introduced into the NHS. We've talked about Pharmacy First and the expanded role there, and also the importance of having independent prescribing. We're also seeing skills move not just within the silos, the traditional silos of the profession, but stretching broader into those areas perhaps other professions would have covered previously. In the light that there's new legislation around regulation, is it fit for purpose? Are there other changes that we need to see to the regulatory framework in order to ensure not only that there is clarity of role, but also that patients understand that clarity of role, and how can that be improved?
Yes, thank you. Just trying to think where to start, because there's a lot in there. Just on clarity of roles, perhaps to begin with, one of the messages that we've had from our discussions with patient groups in different ways and a panel that we run is a recurring theme around a real willingness to and openness to being cared for by pharmacists and pharmacy technicians, perhaps in ways that people haven't been used to. And as one patient said to me very clearly, I don't care who they are, as long as they know what they're doing. So that from a professional point of view, we often spend a lot of time worrying about labels and titles and things, but that was just a different point of view on that. In terms of regulation more widely, I think there are a couple of things to say. One is around professional regulation generally. It has been for many years the subject of discussion around reform, and there's, as you know, an order going forward to begin the reform of GMC procedures. It's really important, I think, that we that I would take this opportunity to commend to the committee the agenda around reforming professional regulation to streamline processes, to make sure that the regulators have the tools that we all need and can use in a...
What do you mean by that?
Well, for example, in making decisions about fitness to practice in a more agile, rapid way, for example. Those issues cut across all the health professions regulators, but there are some specific issues relating to pharmacy that it's worth picking out. So the way in which the pharmacy regulatory regime was set up in 2010, when the GPHC was created, involved, as you know, the regulation of individual pharmacy professionals, pharmacists and pharmacy technicians, through the GPHC, very much along the lines of GMC and GDC, NMC professional regulation paradigm. As well, we have this unusual, if not unique, arrangement whereby pharmacy premises, community pharmacy premises, legally defined as retail, are registered and regulated by us and inspected by us. So they don't come within the remit of the Care Quality Commission, for example, in that respect. That regulatory jurisdiction of ours is based on a building, the premises being registered. That made sense, perhaps, when it was originally designed. I think that's something that needs to be looked at because, of course, services are now operating in a way that is not necessarily tied to a particular building. We've seen some of this with some of the online issues. There's also a question about entirely sensible question and discussion to be had around whether other models of regulation might be more appropriate or relevant going forward in pharmacy, such as whether the business entities themselves should be regulated, which they're not currently, actually, strictly speaking, which is a contrast, for example, with the General Optical Council. And then, additionally, I think it's incumbent on us working with the other regulators, including in England, particularly CQC and MHRA, to make sure that between us we don't allow anything to fall between the cracks. There is a gap, a regulatory gap, which I might take the opportunity to draw to your attention, which is linked with this business about pharmacy premises being regulated by us. Where a business sets up a service using pharmacists to provide clinical care, but not through a pharmacy, that's not liable to be regulated by us because there isn't a pharmacy, if there isn't any supply going on. But equally, it falls outside of this Care Quality Commission jurisdiction because it's a pharmacist service. So that gap has been something that we in CQC have. I can write to you if it's helpful to give you a bit more background on this. But that's a gap that we in CQC have agreed ourselves that we would want to see closed, and we've asked government to look at that. So I think it's important. I mention it as an example, really, of just needing to look perhaps creatively at all of these, the regulatory kind of furniture to make sure that it is right for the future and not an old model that's not serviceable. We've got a piece of work planned for this year to look at that from our point of view, and it's possible that as a result of that we ourselves might suggest legislative change around some of those issues.
Very, very quickly, on the issue of businesses and buildings, should that transfer to the CQC, are you suggesting?
No, I'm not necessarily suggesting a solution. I'm just flagging, I'm at this stage flagging, there's an entirely sensible debate to be had about that, because the further away service design gets from being tied in a neat way to a particular building, the more strain it puts on a regulatory model that was designed in a different era.
If I can turn to you, Mark, I saw you nodding away there, so do you want to respond to that? And then I've got a further question for you.
Yes, it won't surprise Duncan to hear, because we've maintained a position for years. We believe that premises, community pharmacies, should be looked after by the CQC. No question about that whatsoever. Not only that, the business owners need to be regulated. And in community pharmacy, there's a unique situation where we have non-pharmacist area managers. These are people in a very, very substantial position of influence within healthcare. Now, if you look at other sectors, take finance, for example, people in positions of influence are being regulated by the regulator. Why does that not happen in community pharmacy? So a classic case in point is where a pharmacist might decide not to sell a particular item to a patient because it's not safe. And we've had situations where area managers have got involved, taken the thing off the shelf, sold it to the patient and said to the pharmacist, you ever do that again and you're in trouble. We've got to involve the regulation of people who operate the businesses and the non-pharmacists in the healthcare space. We believe the right place is the CQC, and we believe that the GPHC should concentrate on the people regulation. And as Duncan says, not only now is community pharmacy much more integrated with the wider healthcare patch and the delivery of the services, that kind of regulation would not just give patients more confidence, but it would give the people, the workforce, more confidence that if they have issues with their workplace and with their environment, there's a regulator that's got good track record of dealing with these situations elsewhere. And we often have said to the GPHC that the position is quite overwhelming for the GPHC, the amount of stuff that goes on in community pharmacy. So that is something that we would certainly back 100%.
Just again, because of time, just being really quick, the issue of commissioning, obviously we've got a new structure within the NHS with ICBs. What role should pharmacists have within the structure of commissioning at that level?
So it's like a football team, isn't it? It was an analogy that was used in the November session. If we aren't careful, we're going to have the focus on all the strikers. But we need the defenders in there, we need the wingers in there, and most importantly, we need a manager. The ICB should be the manager of what goes on in that healthcare patch. It should deploy the resources, marshal the forces, make sure that we don't have silos going on. For that to happen, there needs to be a multidisciplinary team in the ICB. There needs to be a chief pharmacist at ICB level. That's really quite important. Beyond that, for example, the ARIS funding that was given to have a whole army of PCN-funded pharmacists, if there was an army of healthcare professionals that could be deployed in any of those healthcare settings, so in a doctor's practice, in a care home, in a community pharmacy, it would enable the primary care organisation to deploy the forces far more effectively than is currently the case. So the big argument about all these pharmacists being taken out of community pharmacy to go and work in GP practices, we've got no problem with pharmacists being employed by a PCO, but let's deploy them where they are needed and not just send them into one particular corner, because it just continues to support the broken system.
And finally, and it's a question both to Mark and Nicola on the issue of training. Clearly, the government's put forward a high ambition for increasing the size of the workforce. Without having the experienced clinicians providing the training, then clearly that won't stand up. Have they got the balance right moving forward? Mark, if I start with you and then Nicola.
We saw a huge increase in the number of schools of pharmacy back about 10 years ago. When I was a pharmacist, there were only 18 schools, and now there's nearly double that number. And there have been problems at the university schools, because in the same way as the community pharmacy workforce is stretched, the academic workforce is stretched. Where do you get the experience to suddenly double? Now, there's talk of another half a dozen schools opening, so that's going to give somebody, I suspect the regulator, a lot of work to do to make sure that all is done properly. The next bit is the whole IP supervision process. We've now got a situation where, at this moment in time, there aren't enough qualified independent prescribers in the community pharmacy setting to supervise newly qualified IPs as part of their training. That's going to be a really, really big quandary, and it's a square, we've got a circle, we've got a square. That's got a big challenge for the sector to make sure that that gets in place. And then the final thing that I would say for community pharmacy is, if you look at GP practice, they get funding to train their people. Community pharmacy does not. So in an awful lot of situations, our members are being told, unless you're fully up to speed, we're being told this now with the Pharmacy First service, if you're a locum, if you're not fully trained by February the 1st, don't even bother coming here to work. Now, that's no way to motivate a workforce to get people skilled up and trained up. And yet in other sectors, particularly in the land of GP practice, you've got budgets for training, you've got budgets for infrastructure changes and improvements. This doesn't happen in the community pharmacy setting, and that really does need to change.
Okay, Nicola, have you got anything to add to that?
Absolutely, yes. So for pharmacy technicians, year on year, we're actually growing a number, which is really promising given the wider picture and pressures that we have. So in December 2023, we had 25,768 registered pharmacy technicians, which is amazing. And we're seeing that professional recognition, but what we need is support for continued professional development. So we need the space to be able to learn. That's how you're going to continue to grow the workforce and retain those that are already there. And that's across all sectors, so that's hospital, community, and everywhere that you would find pharmacy professionals, because that's an emerging place as well. Also cross-sector placements, because at the very beginning you'll have training taking place in multiple areas, so when they're qualified you have pharmacy professionals that are experienced in a number of areas, again, skilling them up for the future, maximising their time and training. It's all about the environment that takes place in and the places that they operate post-qualification as well. So, thank you.
Quotations. Yep, thank you so much.
All right, thanks very much. And then finally, Paulette Hamilton.
Right, mine will be quick. Okay. Mark, my first question to you, it's relating to these independent prescribers. People have alluded, you've talked a bit about it, but the question is there a strategy that's going to come into place? How long will that take, and how will that be implemented with all the different issues that you're talking about within this sector?
So the independent prescribing possibility is an astonishingly exciting opportunity for anybody that's thinking of being a pharmacist or actually is being a pharmacist. It's not new because we've had a slow build-up of independent prescribers throughout the whole of the UK. But when you look at what's worked and what has not worked, in Scotland, a significant proportion, the vast majority of independent prescribers still do not use their independent prescribing qualification on a daily basis. Or at all.
And I say that's what happened in nursing.
Yeah.
They didn't use it because it was so narrow, it was so difficult to use it that people gave up on it. Carry on.
I think you've hit the nail on the head there. The answer to your question is a strategic one. We don't just put a community pharmacist with an IP qualification and make them a better community pharmacist. We give them an important strategic piece of work to do. And alongside that model we were talking about earlier, if you have an independent prescriber that's using their IP qualifications every day to resolve those patients' medicines-related needs without having to send the patient back to the doctor, without having to use these serious shortage protocols, able to change the doses, maybe even monitor the blood levels of whatever medication there is to change the doses up or down, that would mean that IP would have to be using that qualification as part of their day job. If they were doing that, you'd have a successful way forward for broadening out independent prescribing to pharmacists and focusing on their unique skills.
Fantastic, thank you. Nicola, without leaving you out, my question to you around technicians. What do you think, going forward, if you were to give a recommendation to the committee, we need to do to really put pharmacy technicians on the map?
Is The million-dollar question, and I'm so glad you've asked. It starts with enabling the profession. So the question that has come out in the consultations that we've got is the first step for that. So we've had the patient group directions consultation that's closed. We're waiting on the outcome of that. That's going to be a massive enabler for the profession. And we just need to make sure that the professional recognition is there. Supervision is the one that's out at the moment. Again, we need pharmacy technicians to be professionally recognised for the autonomous pharmacy profession that they are. They have so much potential, and we just want to make sure that those policy makers and influencers recognise that, because the capacity that it could support, the patient safety that it could support, we're here and we're ready, but we need the enablers around legislation to be able to do that. The Medicines Act from 1968 had a very different patient cohort that it was looking after. Now we have an ageing population, we have more demand than ever, people are living longer with more complex conditions, and we're saying pharmacy technicians are here and we can support that, but we need the enablers to be able to help us.
Thank you. And my final question to you, Duncan. As a regulator, I think primary care is definitely the vehicle to go forward. This morning, through all the questions that have been asked, I think it's difficult right now for it to just go forward as smoothly as it needs to happen. As a regulator, what are the 2 things you think your area could do to help make the vehicle of pharmacist technicians? I know you don't regulate. Do you regulate them?
We do, yeah.
To just help them to really get into that primary care space. Everybody talks the talk, but Duncan, it really, because they're privately owned, they're not always, they're controlled sometimes by working closely with the GPs. They're quite independent bodies. You know, was it Deborah, the lady at the beginning, who runs a completely private service? How can we put that into primary care?
Well, that's a big question which goes, in many ways, I would say, beyond what I can help with. But I would say we as the regulator have got a key role to play directly in terms of particularly with the strategic piece around workforce competence and capability, because we set and uphold the education standards. We have got, in parallel with all of the work we're doing about initial education and training, equally, if not actually more importantly, dare I say it, we've got a group looking at everything to do with how we and others assure practice of people who are already on the register. So that includes things like looking at revalidation, looking at governance, clinical governance in pharmacy, because that's all key to confidence and self-confidence of our professionals, but also the confidence of the public and other health professionals. We need our doctors and nurses to be confident in what our pharmacy teams can do as well, don't we? So that's part of it. And one thing which we haven't talked about this morning, because I guess it's not within the scope of the workforce topic, but just if I could just cheekily say, the other thing that I would say we would be flying a flag for is everything to do with integration of records, because that is so we know that's so fundamental to safety and to effective, efficient, smart working. And I would say not just within NHS organisations and NHS care providers, but I would encourage us collectively to really look hard at the question of how on earth can we integrate private provision within that as well, because where you've got independent providers not able to connect with other records, there are clearly safety issues around that. We've seen that sadly in many coroner cases.
Thank you for that. Thank you. Back to the chair.
Thanks very much. Right, well, that concludes today's session. So we've heard from the Pharmacists Defence Association, the General Pharmaceutical Council and the Association of Pharmacy Technicians. We are very grateful to you all for your time. We will continue our deliberations as we produce our report for ministers. So thanks very much for coming in. Order.